Thank you to give me this opportunity to lecture about updates on some anatomic entities of the posterior fossa. I will show you how we can go from prenatal imaging with Canon to genetics. Let's begin with the first case. This patient was referred at 25 weeks due to ventriculomegaly and abnormal CNS organization. This is two-axial view of the supratentorial structures and the posterior fossa, and the mid-sagittal view. We are at 25 weeks of gestation. What do you think about the operculation of the Sylvian fissure? You cannot see, in fact, the Sylvian fissure. Instead, you have an outer athyric band of tissue here on the cortical surface, and we can see also this ecologic band on the surface of the cerebellum. And you can see also this band surrounding the brainstem. Because of this ecologic band, you have disappearance or reduction of the supratentorial space, as you can see also on the MR. If you look at the mid-sagittal view here, you have a Z-shape appearance of the brainstem and a digenesis of the corpus callosum. You have the same image here, when you can see the Z-shape, but the outer band is less visible with MR compared to ultrasound. Because of the most likely poor prognosis of these conditions, termination was performed, and you have the macroscopic and microscopic features at pathological examination. If you look at the ecologic band, it is well visible here on the macroscopic examination, and there is here the histology. This is extracortical neuroglial layer, which is over migration, and this is pathognomonic of cobblestone lissencephaly. If you go to the posterior fossa, here, you see that the overmigration is here, surrounding the brainstem, also surrounding here the cerebellum, and you have the Z-shape appearance of the brainstem, and this is due to the fact that the brainstem is in initial embryonic appearance that you found at 8 weeks of gestation. So I show you a case where you have a specific prenatal imaging patterns of the Walker-Warburg syndrome, which is related to cobblestone lissencephaly and overmigration. And you can have this diagnosis and make this diagnosis on the basis of the outer athyric ecologic band on the cortical surface in the supratentorial space, not identified using MR, and you have the same band of tissue in the mesencephalon and brainstem. And the consequences is the reduction of the disappearance of the precerebral space, clearly demonstrated using MR, and the Z-shape appearance of the brainstem encased within overmigration and preserved in its embryonic configuration. We can do this diagnosis as early as 14 weeks, as we did in the article. And when you see this prenatal pattern, you are most likely sure that it's related to two genes, POMT1 and POMT2, which are the most frequent genes involved in Walker-Warburg syndrome. So you have all the information in this article. Let's go to case 2. Case 2, oh, sorry. Case 2, its patients refer at 21 weeks of gestation for cerebral and extracerebral anomalies. Just have a look at the posterior fossa, an axial plane at the levels of the pons, and a mid-sagittal plane. You can see that there is frequent indication between the inferior part of the fourth ventricle and the fluid space, the retrocerebral fluid space. And on the mid-sagittal view, you have a small hair vermis, which look maybe like a black post cyst. But if you look here, a little bit above, at the level of the superior peduncles, is pathognomonic of the disease. If you move this like that, it's more evident if you know the findings. This is, in fact, the molar tooth size, which is pathognomonic of Joubert syndromes and related disorder. This is a postnatal view with normal peduncle, superior cerebral peduncle here, and the fourth ventricle here. And look here, you have thickening and elongation of the peduncle, and you have the fourth ventricle here. So you have a typical molar tooth sign, which is, in fact, pathognomonic of this disease. You may have also extracerebral findings, such as echogenic kinase. Most of them are large and associated with some cyst within it, and a post-axial polydactyly, as seen here. But these extracerebral features are inconsistent. So the main feature is this molar tooth sign related this to horizontal orientation and thickening of the superior cerebral peduncles, but this leads to modification of the shape of the fourth ventricle, and this modification is easy to recognize on routine examination. And we publish this article on the specificity of the modification of the changes of the shape of the fourth ventricle, and this is summarized here. In the normal life, in fact, the AP diameter of the fourth ventricle is shorter than the transverse diameter. Because of the elongation of the peduncle here, you see that the AP diameter becomes larger than the transverse diameter. So if you see this, this is very pathognomonic of Joubert syndromes. And when you know that Joubert syndromes are related disorders, you have a panel of genes, because there is many genes, more than 30 genes, involved in these conditions, and you can go straight from the images to the genes. Let's move to the third case. It's, in fact, two patients showing a similar pattern. This is the first patient. I saw this patient 3 years ago. It's the first pregnancy, history of consanguinity, and this patient was referred for ventriculomegaly at 26 weeks, associated with club feet and arthrogryposis. You are 26 weeks. We can confirm a ventriculomegaly for sure, but look at the Sylvian fissure. Is it a Sylvian fissure of 26? No, it's a Sylvian fissure at 22 or 21. So, annular Sylvian fissure. Look at the frontal horn. What do you see? You see, in fact, two echogenic masses protruding in the frontal horn. And when you look at the posterior fossa, there is a reduction of the TCD and also a mild microphthalmia, as you can see here. Now, if you do MR, this is the MR, and this is the control. You can see here the cortex, which is well visible. Look at the cortex here. There is a cortical ribbon thinning. There is a pseudo-lissencephaly appearance, thin cerebral, and also voluminous germinal matrix here and here, protruding in the frontal horn. If you look at the posterior fossa, there is vermen dysgenesis and the brain stem dysgenesis with a Z-shaped appearance and typical elongations of the pons here. It's too long compared to normal. This is the posterior MR. On the posterior MR, there is, in fact, here some cysts within the germinal matrix, this multiple germinal disease cyst. And look at the pons. It's very abnormal. And we have confirmation of club fit, arthrophytosis, and microphthalmia, diagnosed prenatally, and it gave to early neonatal death. This one was similar to this case. I've seen this case in 2003, similar large germinal matrix, similar pattern of the cortex, and look at the brainstem, it's exactly the same thing, associated with club fit and arthrocryposis, with cardiac anomalies, and in that case, there was continuation of the pregnancy, death at 4 days, and no pathological examination. But the patient has a recurrence in 05, and it's the same thing with major here, large germinal matrix. We report this case in a series of abnormal Cedian fissure, but at that time, we don't know the genes. Because of that, we recently have a look at this article about mutations in tubulin genes, which give, in the most severe case, microencephaly and also voluminous germinal zone and ganglionic eminence, but also brainstem dysgenesis. This kind of case you can see here in the publication with the voluminous germinal matrix. And our case was very similar to the case reported by Poretti and Balthauser about ventriculomegaly and brainstem kinking. And you can see here that you have very large germinal zone. And look at the brainstem, it's the same thing. And in the article, they said that the possibility of tubulin was raised, but not confirmed genetically, as in our case. We test tubulin, and it was not tubulin. Because of that, we do a whole exome sequencing, and a new gene was in fact discovered, this gene, and we recently published a collaborative study with Alexandre Raymond from Lausanne, including 10 families, and we have 6 prenatal or neonatal cases showing exactly the same pattern, which include severe cerebral malformation, mimicking the most severe case of tubulopathy, with a lissencephalic cortical pattern, severe parenchymal thinning, voluminous germinal matrix, severe ventriculomegaly, and cerebellar and brainstem dysgenesis. But in tubulopathy, you don't have extra CNS anomalies, and all our cases have clubfoot and arthrogryposis, and also visceral anomalies involving most of the time the eyes and the heart. So when you have this kind of findings, think about this new gene, and we have a poster about this entity. So I show you 3 entities. The new genes, Walker-Walbert syndromes, and Joubert syndromes. And as you can see here, you have perfect correlations between the sonographic findings and the MR findings for the new genes, for Walker-Walbert, and also for Joubert syndromes. So these correlations between MR and ultrasound can be easily achieved with fusions, as here, this is the most frequent case. And when I discuss with a student about Chiari malformations, it's difficult to understand why in Chiari malformations, it's very difficult to analyze the posterior fossa. Because, in fact, there is disappearance of the pericerebral space, and because the size of the posterior fossa is reduced, and here you can easily understand because we have the exact correlation between absence of the fluid surrounding the cerebellum, the banana sign of the cerebellum, which is typical for, in fact, carry-1 malformation. And because of that, most of the time, there is dilatation of the ventricular system. And you have also something that you may have seen, and you can, what's this? You see, you will see when we come back to the supratentorial structures. This here, this is connection with the third ventricle. It is the suprapineal recess. And you know that the suprapineal recess, which is in fact in connection with the third ventricle, which begin to dilate before the dilatation of the ventricular system. So in most of the cases, you have this small cystic structure, which is the suprapineal recess. So I think that it's, for me, clear that for academic purpose, it's very nice to do this kind of fusions between MR and ultrasound. And if I ask you what's the gestational age of these patients, and we'll speak about this later, I think on Monday, yes? You can see here that you have the insula, and this insula is recovered halfway by the temporal lobes. You have also here the superior temporal sulcus, and because of this is a pattern which is typical of a patient at 28 weeks of gestation. And you can do this analysis on ultrasound and MR. So just to show you that when I scan, I go from top to down, and you see that the midline stay in the midline. It's very important because of that. I can move my in my hand my probe, and I have a perfect, not perfect, but more than I can, axial coronal plane, and I move back to the axial plane. And so we are discussing about posterior fossa. So here is the posterior fossa, and you can see here that you have the two hemispheres, and that they are symmetric. You have the echogenicity of the vermis, which is always more echogenic than the ventricle, and you have the fourth ventricle here, and the AP diameter is less than the transverse diameter. And here, it's the pericerebral space, and you measure the pericerebral space where it's the larger part here, and the largest part, and it should be less than 10 millimeters. When you can also have a view of the foliation. The foliation is like the sulcation on the cerebellum, and you see here the vertical foliation, and in some cases it can be horizontal, and it will change the echogenicity of the hemisphere. You may see also here clearly the third ventricle, and between the third ventricle and the fourth ventricle, you have the aqueduct, and you can follow the aqueduct. You see the aqueduct, you have the lumen of the aqueduct here, and you can follow the lumen till almost the end here. I try to show you this here. And in some cases, when you have, in fact, isolated ventriculomegaly with a dilated third ventricle, you may have the diagnosis of, in fact, aqueduct stenosis, because you don't see the lumen of the aqueduct, which is clearly visible here. So for this patient, I think what an important thing is to know at what age gestation we are. So you see that you have here the insula, here, and the temporal lobe here. The insula will be recovered by the temporal lobe at 32 here, 28 here, 26 here, and we are between 26 and 28 here, and we are around 27. In most patients, we have here the superior temporal sulcus, and this patient is close to 27. So if it's 27, you can expect what is the TCD. 27, it should be around 30. So if you put here, you see, it's not far from 30. So in fact, if you don't know the age of the pregnancy, the maturation of brain gives you, in fact, the indication, and here you can conclude that the patient is around 27. Here you see clearly the cavum septum pellucidity, and you know just mnemonic way of reminding here the cavum septum pellucidity should be the AP diameter should be larger than the transverse diameter in the inverse of the first ventricle. If you have a case where the AP diameter is in fact small and in fact smaller than the AP diameter, you may go to digenesis of the corpus callosum. So if you have any question on the axial plane, you see here clearly the peduncle. We can also move to the coronal plane, but I will try to do. The patient have a C-section, so it's a little bit painful when I press, so I don't want to press too much. And the baby just move. It's a real life. So you can appreciate an oblique view on the cerebellum. I go back to, okay, back to axial. You can see clearly the eye. Try to be a good boy. Or, So you see at least the corpus callosum. I'll try to show you. In such case, it's difficult to show the vermis, for sure. I have to wait. You have any question for the axial plane? Maybe? I can show you one thing. It's if you are at 26 or more than 26, you can see also the central sulcus. The central sulcus is when you go up here, you see this small sulcus here. This is the central sulcus here, and it appears around 26. So, and at 28, the sulcus is almost here. So it's a small depression at 26. So we are between 26 and 28 because we are 27. So just to show you, sometimes it's difficult to have a look at the proximal hemisphere. And in such case, when I want to have a look at the proximal hemisphere, I do an oblique view like that. This oblique view is not for measuring the ventricle because it's oblique. So it's impossible to measure the ventricle because, in fact, we increase the size of the ventricle. But when you look, in fact, at the ecogeny of the plexus is occupying all the ventricle. So I'm quite sure there is no ventriculomegaly. But look here at the parenchyma. And we can have a look at calcification when you are dealing with toxoplasmosis or CMV infection. It's very convenient to use this view, or even when you have asymmetry ventriculomegaly and you are looking for some tiny clot within the ventricle. When you do that, you see the lumen of the ventricle. You can see also some nodularity when you have subependymal heterotopia. So this view is really of help when you are doing examination of the fetal brain. For sure, it's not routine, but when you are with expert in the fetal brain, I think it's a very interesting view to have this kind of information. And because most of the time we say that it's impossible to explore the proximal hemisphere, doing that, you see that it's in fact very easy to explore the hemisphere. So to do that, I put my probe in an axial plane, and I just to do an inclination of the probe, and to do that, and I can have a look at the temporal lobe here, more the occipital. If I want the occipital, it's more occipital here. You see the parieto-occipital fissure, which is clearly visible here. So it's a very interesting view. So let's, I don't think I will have more chance with the sagittal view, but I will try. You may ask me what are this line here facing the temporal lobes. In the temporal lobe, the pericerebral spaces are large, and there is some vein here, and it's joining vein in the subarachnoid space that you can see. You see clearly here that you have, this artery, which is typical of the fetus, which is a yelloid artery, and this yelloid artery will disappear around 32, and remain when you have some kind of microphthalmia. Or if you have any question?
Yes. Could you please show us again where do you calculate the cisterna magna?
The cisterna magna?
Yes.
Okay.
You prefer to calculate from the hemisphere or the vermis?
Where I measure it where it is large. For me, if I have to measure it, the larger part is here. So
from the hemisphere?
Yes, it depends. Because in some cases, you have asymmetry of this pericerebral space because you have an arachnoid cyst. So if you are an arachnoid cyst facing this hemisphere, you measure here. In some very large megacisterna, it will be larger in this part here. So you will measure here. So yes, you have to measure in fact, the larger part of the retrocerebral field space. Okay?
Okay. And another question.
Yes.
Could you please show us the posterior complex?
The anterior or the posterior?
Posterior, yes.
Yes. I published about the anterior complex, but I will show you also the posterior. When I publish about the anterior complex for people we are not aware about this complex include the cavum septum pellucidum, here the genu of the corpus callosum, here the two frontal horn, and it's very interesting because here you see that this one is smaller than this one, so you are very confident in the fact that in most cases, you will not have any ventriculomegaly on the proximal hemisphere. And you see here, in fact, the interhemispheric fissure. And here, you have the supracallosal sulcus. So this is anterior complex. And Vidals published about the posterior complex, which is, in fact, here. You have the same kind of images with here. This is the fibers of the corpus callosum, but you are not sure here that you are dealing with the splenium, because you can be on the posterior part of the body of the corpus callosum. So for me, it's interesting to see the posterior complex here. But in that case, it's very difficult to say the corpus callosum is complete or not. The only way to be sure that it's complete is to do a sagittal view. So I will try to do, I will press a little bit hard just for a short time. I don't want to press too much because it will be painful for the lady who had a C-section. So if you have any other question?
More
Yes?
question? You? No. Okay.
Can you show us the optic chiasma?
Huh. Depending, yes. Here, you see, I will try to show you. In fact, we have here the optic nerve. So what you do, you go to the cavum septum pellucidum. You go to here, you are on the trigon, here, the pillars of the trigon, and just below, you have here. So you have the polygon of Willis. If you put the Doppler, here, the polygon of Willis, and depending of the larger of this space, you may see that you have here two bands of tissue, which are the optic nerve, and here is the chiasma, where the two optic nerve here join at the optic chiasma. So in some patients, you see here, okay? You see? Do you agree with me? Just, you can say no, but yeah. It's depending of if we have large peripheral space, it can be easy. But here, for sure, you see there is optic nerve. But to measure the optic nerve and say they are normal or abnormal, it's very tricky. I know that Jean-Philippe Beau have a good presentation about optic nerve using 3D, and I think we can do that without 3D, but the main issue is to be sure if it's normal or not, and it's very subjective measures, in fact. Okay?
I think it's time.
Yeah, it's time.
Okay, so great thank you to
Okay.
the patients. She was a great, and the baby was a great baby. Sorry to press a little bit hard, but thank you for all. Thank you.
Thank you. Okay, thank you very much.